I shall be next explaining to you regarding type 1.5 diabetes, which initially might look like a very intriguing term to you, but I'm very sure you are familiar with what 1.5 diabetes is, and the technical term that we're going to use to describe it, as was asked in previous year questions, is called as LADA. LADA would stand for, let's just work up the full form, that is latent autoimmune diabetes in adults. Now, why is it asked? Is, as you can see, because the etiology of this is autoimmune, so that's going to be same as that of type 1 diabetes. But the age of presentation of this disease, you can see that LADA will present in adult age group. So clinically speaking, mark my words there, clinically speaking, if he asks in the exam that is it a variant of type 1 diabetes or is it a variant of type 2 diabetes, you see etiology wise it's going to be a variant of type 1. But clinically speaking, the age of presentation is that of an adult. So in the exam for a single best answer, your answer will be that LADA is a variant of type 2 diabetes. One of the fundamental difference in this condition is, however, the etiology is different in a sense that in type 2 diabetes, the problem is with the receptor, and in this case, it is an autoimmune etiology. Now, since I've highlighted this word autoimmune almost 2-3 times, so you would be wondering what's the big deal about it. The big deal is that in the exam, he would love to ask you regarding the name of the auto-antibodies. You see, in type 1 diabetes, you answer autoimmunity, cool. But here he will definitely ask you regarding the auto-antibody involved. And the name of the antibody is little a peculiar one, so you need to remember actually two of them. That is anti-GAD, I'll just tell you the full form in few seconds from now, and anti-ICA antibody. The first one is one that I would definitely like you to remember the name, that is glutamic acid decarboxylase antibody. The significance of this will also come up. The second one is relatively easy. So I have usually not seen examiners asking the second one because this you can still guess even if you have not read it the first time. This would be ICA, that is islet cell antibody. So do remember the names. That is anti-GAD and anti-islet cell antibodies are the reason why type 1.5 diabetes would develop. Now, what is the significance of knowing about this autoantibody is that this is also encountered in a condition called as stiff person syndrome. So you can take this as an additional information. Stiff person syndrome is a paraneoplastic manifestation of oat cell cancer. You are anyway aware that the most aggressive lung cancer is oat cell cancer. It's rather a very nasty one. So in the exam, he definitely will love to ask you regarding paraneoplastic manifestations that are seen with small cell cancer, also called as oat cell cancer. Though I will slightly deviate from the topic, but it will be worth the effort. You are all familiar with the fact that this cancer can synthesize antidiuretic hormone in excess and can cause even a dilutional hyponatremia, that is SIADH. It can also contribute to excess synthesis of cortisol, and therefore you will read about ectopic ACTH production and then Cushing syndrome manifestation developing in the patient. In fact, in neurology, I have spoken regarding the autoantibodies produced by oat cell cancer contributing to damage to the neuromuscular junction in a sense that it is reducing the amount of acetylcholine production. Now, if the amount of acetylcholine production will reduce, then there will be a manifestation which would be called as Lambert-Eaton syndrome. You can understand the highlight of this, that in myasthenia gravis it is antibodies against acetylcholine receptor, but here the production of acetylcholine is reduced thanks to the antibodies produced by this nasty cancer. And today I'm telling you that this cancer can also be causing this physical disability in a person referred to as stiff person syndrome, and the autoantibody documented is same as that in LADA, that is type 1.5 diabetes. Once we get the autoantibodies right, then he would ask you regarding the treatment part. Now, the first common sense or the first thought process of anybody would be that we will use insulin for the treatment of this condition because there is a insulinopenia. You see, like in type 1 diabetes, there is an insulinopenia. Here also there is an autoimmune destruction, so there is an insulinopenia. But first line management for this person would not be answered as insulin. We can use insulin, but what we prefer is usage of drugs that will rather increase the amount of insulin production from the beta cells of pancreas because all are not destroyed. Therefore, what we will use in this condition will be sulfonylureas. In fact, this is itself a multiple choice question because traditionally speaking, you are all familiar that in type 2 diabetes, we start treatment with metformin. So he will ask you, in which type of diabetes would you start treatment with sulfonylureas? You are familiar that sulfonylureas are capable of producing a burst of insulin, and the spike of insulin will help in regulating the blood sugar values. Usually the drug that we use for management of this would be answered first line as glipizide. So I reiterate the question once again. If he simply says in the exam that what is the first line treatment for management of 1.5, it is sulfonylureas, or for that matter of fact, he can say that in which type of diabetes would you prefer starting with sulfonylureas, then the answer is not type 2 diabetes, it is 1.5 diabetes mellitus. Now, since I spoke about insulin here, so I do have an opportunity to talk about some pharmacological issues. You would have read about rapid acting insulin, short acting insulin in pharmacology also, but listening to me for the next few minutes would definitely sharpen your skills when it comes to answering for the various types of insulins. Do remember the fact that the only type of insulin that can be given intravenously is regular insulin, which is short acting insulin. Now, I have just jotted down some names here ranging from intermediate to long to ultra long acting insulins, and you need to be familiar that which of these are recommended, especially when it comes to type 1 diabetes mellitus, where insulin is the mainstay of treatment or the mainstay of prolonging the life of this person, and I would rather say the quality of life will also be improved. So do remember the fact that ideally whatever insulin that you're giving to the person, this should be 50% at least a rapid acting insulin. Now, rapid acting insulin would be names like Lispro, or it would be Aspart, or it would be Glulicine. While I'm writing down the third name, question from my side to you guys is that this rapid acting insulin injection should be given how many minutes before the meal? You see, if you give a subcutaneous injection of, let me say, Lispro right now, it will start neutralizing carbohydrates, but there will be some time lag because you have given the injection subcutaneously, so it will take some time for the blood levels to rise. The onset of action is approximately 20 to 25 minutes. So whenever you are prescribing rapid acting insulin to your patient, you need to tell the mother, especially mother, because we're talking about type 1 diabetes, the mother has to be told to give something to the child to eat within something like a range of 20-25 minutes of this injection being given, because once it starts acting and the child is not given anything to eat, children don't eat by themselves, there's a distinct possibility of the child developing hypoglycemia. The short-acting insulin is the traditional regular insulin. As I've highlighted before you, this can be given subcutaneously. The advantage is it can be given intravenously in metabolic emergencies. Emergencies can be diabetic ketoacidosis or non-ketotic hyperosmolar coma. And after how much time will this injection work? So this would be approximately 30 minutes. When it comes to intermediate, well, we have a lot of varieties available, but one of them is NPH. The full form of NPH, I think all of you are familiar with. That would be called as neutral protamine higdon, and the question can be asked as it will start working after how much time. Your answer in this case will be given as 2 hours. When it comes to long-acting insulin, this single shot will work for approximately 24 hours. The injectables would be glargine or will be detemir. Now, please remember that when it comes to long-acting insulin, the total duration is 24 hours. And if you look at the curve, you see normally whenever you give a shot of insulin, like let me represent this on the x-axis, the time of the day and the night. When you give a shot of any form of insulin, like a rapid-acting insulin, the drug levels will peak after 20-25 minutes. The drug will act for 4 to 6 hours maximum, and then the effect will wane away. Then again at lunchtime, you will give a shot, the injection effect will occur, and then the effect will wane off. So you can see that when you give rapid acting insulin, all of these insulins will be having a peak therapeutic level, and then the effect will wear off. But when it comes to glargine being used, let me say glargine was given the night before, then the effect will last for approximately 24 hours. So in multiple choice question, what they have simply asked is which of the following insulin is called as a peakless insulin. That is simply to highlight the fact that there is definitely a peak of every type of rapid acting insulin. In fact, all of them will have a peak therapeutic effect, then the effect will wear away. But when it comes to especially glargine and determine or the ultra long acting ones, that is where the peak is not present. So I would just like you to remember the fact that the long and the ultra long acting ones would be referred to as, especially the long acting ones would be are the common ones used. So that is what is usually asked in the exam. That would be glargine, detemir or peakless insulin. Ultra long acting one, well, the name has already been told to you, you are already sensitized to it, that is degludec. And the total duration of action in this case, you just need to invert the numbers. Instead of 24, just make it 42, that is 42 hours. So bottom line is that insulin is going to be useful for type 1 diabetes. It's useful in type 1.5 diabetes, and even in type 2 in the later stages of the disease, specifically when the person will become resistant to the effect of oral hypoglycemic drugs. In fact, what I'm saying now, you are familiar with this because I have said this earlier also, but let me just highlight the facts once again. Just now I was saying that if you are having a type 2 diabetes mellitus patient and he has become resistant to the effect of oral hypoglycemic drugs, that is when we give insulin. Now here the query from your patient, who's going to be, patients nowadays are internet savvy and they would love to ask you questions. So a person of type 2 diabetes mellitus is saying that, sir, I read on the internet or you had informed me that in my body insulin is already elevated because receptor is not working. So if my already increased insulin is not able to stimulate the receptor, how is it that the insulin that you will give from outside will start working? Smart guy, no? If insulin in the body of a type 2 diabetic person is already increased and it's not able to activate the receptor, then exogenous insulin, how will it work? Well, I want to tell you that in type 2 diabetes mellitus, in the later stages, there is a beta cell exhaustion. I would just like to write this statement here. Type 2 diabetes mellitus patients in the later stages of the illness tend to develop a beta cell exhaustion. At that particular point of time, if you check the radioimmunoassay RIA fasting insulin level in type 2 diabetes mellitus, you will notice that it will not be increased. Rather, insulin levels will be reduced and therefore now insulin will start working. In the initial part of type 2 diabetes, it is drugs. Later on, there's a burnout. Burnout in a sense that there is insulinopenia even in type 2 diabetes mellitus in the later stage. Initially type 2 diabetes insulin is more, but later on it becomes lesser, and that is where definitely the drugs will start working. And I also want to tell you that if it is a newly diagnosed case of type 2 diabetes mellitus, though I represented or highlighted that we should start oral hypoglycemic drugs if HbA1c is very high. The guidelines are usually that if it's a newly diagnosed case of diabetes mellitus type 2 and HbA1c is more than 10%, that already the damage, the micro and the macrovascular damage is substantially high. So I would not like to give a trial of oral hypoglycemic drugs and see whether they lower the HbA1c. I would like recommend the person to start with insulin right away. It's a separate issue that if he is not comfortable, then we can start with oral hypoglycemic drugs. Similarly, if it's a known case of diabetes mellitus in a female patient and she just recently got married, in a pregnancy status, you very well know that diabetes mellitus in a lady who's just recently conceived, she's having pre-existing diabetes, can cause neural tube defects. The most common one is spina bifida occulta. The specific one that you encounter would be sacral agenesis. It could even be craniorastosis, meningocele, myelomeningocele. So I don't want neural tube defects. I don't want cardiovascular defects. Therefore, it is important that even in the first trimester, she should be put on insulin to prevent the teratogenicity, and especially glucose toxicity can contribute to neural tube defects as well as cardiovascular malformations. Similarly, if a person ends up with end organ damage, now implying end organ damage would be like heart failure. End organ damage would mean like chronic kidney disease. The patient has already gone into CKD. In those circumstances, it is again imperative to start the person on insulin. Now, whether we will do a dose reduction or not of insulin is a separate issue, because you see, when you are going to listen to the topic of diabetic nephropathy, I have highlighted that because insulin is metabolized by the kidney, you need to do a dose reduction of insulin. Why? Because if you will keep on giving the standard dose, it will not be excreted. And if it's not excreted, it will contribute to hypoglycemia. So every time a diabetic person goes into an acute illness, like he could land up in diabetic ketoacidosis or non-ketotic hyperosmolar coma, so that is when insulin will usually be recommended. So this fact that I have said, you are already familiar with. So even if you don't note it down, it's okay. But I just wanted to reiterate what you already know. We shall now be comparing information of type 1 and 1.5 diabetes with that of type 2 diabetes mellitus, where we have is a resistance to the effects of insulin, and the question is why. You have an educated patient. He says, sir, you told me that in my body the insulin levels are elevated. The receptors in my body are exhibiting a resistance. He says, okay, sir, I understand the receptors are misbehaving, but why is it so? This was precisely the question that was asked in your exam also. The question said, what is the etiology of type 2 diabetes mellitus? And your answer would be given as polygenetic. Defective genes are responsible for manifestations developing in type 2 diabetes mellitus. Well, what do defective genes cause? There are two things at a molecular level that I would like you to understand, which is again important from MCQ perspective. First of all, due to this defective genes, there would be excess of adipokines in the body of this person, which will promote weight gain, which will promote obesity, and both weight gain and obesity increase the situation of insulin resistance. Apart from this, the second thing that is going to happen in the body of this person would be decrease in the levels of adiponectin. Now, what is adiponectin? So, adiponectin is referred in the textbook as a very, very peculiar terminology. I would like you to listen to this with care. This would be called as guardian angel against obesity. You see, normally we medical people do not believe in God and angels and stuff like that. But here the textbook mentions this word that adiponectin is a guardian angel against obesity. So like I'll put it like this. People like you and me, we tend to have a pizza on a weekend or a burger on the weekend or any part of the day, anytime. Most of us are eating more than what our body requires. Therefore, there's a tendency for mostly urban Indians to put on weight. But still, it would just be a weight gain, maybe a few kilograms over a few years and not a gross obesity. So what is the natural thing in our body which is preventing us from, becoming bloated up after gorging on so much of cheese and pizza and desi ghee and stuff like that? It is adiponectin. But once the values of adiponectin will become lesser, that is when this person will become fat. And in India, if a person is, fat, he's called as healthy. So what I want you to understand is that in type 2 diabetes mellitus, the fat composition or the fat amount in the body is increased. But muscle wasting is still occurring. Because of this significant muscle wasting, though this person will call himself healthy, I'm saying type 2 diabetes is not a healthy person, but the person will call himself healthy because he is hefty, because the fat in the body is more, so his weight may be normal or even higher than normal, going towards, a body mass index of 30. But I want you to understand that hidden below this is severe muscle wasting. So patients of type 2 diabetes mellitus will not be able to work out in a gym or regular exercise. Do we want type 2 diabetes patients to exercise regularly? I'm just using a casual term, couch potato, to highlight the fact that they would prefer sitting at one place. If you ask them, why are you not moving around? The person will say, I don't have the energy. So you will always see this complaint of asthenia or fatigability, easy fatigability that would come in type 2 diabetes mellitus patients. Though they are calling themselves healthy, that's because they're relatively hefty. It's just that the fat in the body is more, but below that, the muscle wasting component is hidden. Please remember the fact that in type 2 diabetes mellitus, it is defective genes which are mainly responsible for the receptors misbehaving. So we will now talk about the treatment of a person who's suffering from type 2 diabetes mellitus. From the treatment perspective, two things should be very clear, that what are you going to first do for the person? And I give you options while I write them down. One is going to be diet control and second is going to be exercise. If you were the physician, what would you advise first? Diet control or exercise? Well, yes, you would first advise diet control. Though this person, when you talk about exercise, is going to be very excited and he's going to say that which gym membership should I take, a platinum one, gold one? But I would suggest him that you don't need to take up any gym membership. I just want him to do light aerobic exercise. Well, what kind of light aerobic exercise? It could be simple jogging or brisk walking. Well, what is so great about jogging? He says, doctor, I have all the money. I can buy the membership of the most expensive gym and you were just asking me to purchase some running shoes and do some routine jogging. One, I'll explain to him that they have to be good quality running shoes. Why? Because these people tend to have diabetic neuropathy. So I don't want this guy to end up with an ulcer on the sole of the foot, which is going to be difficult and nasty one to heal. Because diabetic people either on the heel or on metatarsal heads can have a non-healing ulcer on the sole of the foot. So injuries on the sole of the foot are to be avoided. So that is why I recommended good quality pair of running shoes. Second, what is so great about jogging? So he's a non-technical person, he may not understand this, but you guys are technical chaps, you can understand that with physical exercise like jogging or light aerobic activity, GLUT4 receptors, like on the surface of the pancreas we have GLUT2 receptor, here it would be GLUT4 receptor whose levels will rise, and when the GLUT4 receptors on the muscles will rise, then what is it gonna do? It's gonna promote the entry of sugar into the muscle. Now, mark my words here that borderline cases of diabetes mellitus or people with HbA1c values of 6.7, 6.8, something like that, they definitely can respond with combination of diet control and exercise. The main mechanism of action of light aerobic activities promote entry of sugar intake into the muscle. In pharmacology or other allied subjects, they will say only the word increased peripheral utilization of sugar, but the technical word here is that there is an increased utilization of sugar by the muscles and the adipose tissue. Well, how much of exercise should a person be doing? So that would be something like only 30 minutes per day. And don't make this person work out very hard, because a lot of them could be having coronary artery disease. So you don't want this person to develop an angina attack during a workout or a frank myocardial infarction. The incidence of coronary artery disease is substantially increased in these patients. Both cholesterol and triglyceride can be elevated, resulting in increased incidence of atherosclerosis. It is 30 minutes of exercise per day. That should make him just a little bit breathless. Like if he's attending a cell phone call, the other person can make out that he's a little breathless, but don't make him pant, because the higher amount of workload that he'll be subjected to, the stress on the heart will also increase. Light aerobic activity for 30 minutes per day for 5 days per week, that would mean something like MCQ wise 150 minutes of light aerobic activity per week is sufficient for this person to improve his peripheral utilization of sugar. When I talk about diet control, I am mainly talking about carbohydrates being restricted in the diet. And when I'm talking about carbohydrate intake being restricted, I am not saying that don't take carbohydrates at all. It is just to modify the type of carbohydrates. You see, most Indian foods are wheat based or rice based, and wheat and rice, they have a very high glycemic index. So I would like him to switch to carbohydrates which are having a relatively low glycemic index, like for example oats. Or for that matter of fact, if he's gonna take bread, instead of the traditional bread, he can take a brown, or he can use a multigrain bread. Similarly, now we have available multigrain atta. So instead of the traditional white flour, it's a multigrain atta that would be recommended. If he loves to eat mutton biryani, I'll tell him that red meat is not good for you. It is white meat. So chicken biryani is okay, or like Western patient, turkey is fine. So a combination of whatever traditional food products are there, they have to be used. What I'm trying to say is that if you try to introduce very radical changes, then he's not going to listen to you. So it's going to be standard thing, like I highlighted that if he loves to eat rice, he can just change the white rice to brown rice. And instead of the red meats, it is white meats that are recommended. That could be in the form of chicken, that could be in the form of turkey. Well, let me put up a question before you here for facts. This person who's a diabetic, he had a myocardial infarction last year, and is asking you today, the doctor, can I eat butter and desi ghee? What would be your advice for the intake of butter or desi ghee? Obviously, I understand it's not to be taken in very large amounts. He's just asking you, doctor, can I put butter over my chapati? Or can I put desi ghee over my chapati? What would you advise? He had a MI last year. You see, earlier the guidelines were we used to restrict people from eating butter and desi ghee, but current guidelines are yes, it can be given. Please appreciate the fact that these food products make the food tasty. If you're gonna make this person avoid all this, he's gonna cheat. He's still gonna take it and hide this information from you. So your job is to be frank with the patient and explain to him that you can eat everything. Only thing is, it has to be eaten in moderation or limited amounts. Primarily, the cooking oil that will be used in the house of this patient can be like safflower oil, or it could be sunflower oil, or it could be olive oil. You will notice the fact that in India, it is all about frying. Like even the dal that we eat will have a tadka in it, right? The tadka will be still having frying. So in Western diet, like Mediterranean diet, they just put olive oil on the salad from the top. But in our food, we don't eat oil like that. We fry it and then we eat it. So problem is mainly with frying. Restaurant people are not gonna change the oil in which they cook fries and stuff like that. Like McD will change their oil I think every 3 to 4 days. So if in a restaurant, or like if you go to KFC or if you go to McDonald's, because they don't change the oil, and in the same oil, the food products are being made again and again and again. So the color of the oil also begins to change towards black. You will also notice smoke coming from the oil. That is when trans fats are generated. The most dangerous dietary fat is not butter and desi ghee. The most dangerous dietary fat is trans fats. So you need to tell this guy to avoid restaurant food, avoid KFC, avoid McDonald's, and rather eat home cooked food. Butter and desi ghee are definitely allowed. Protein intake is definitely recommended. Only if the kidney function is very grossly deranged that we will try to restrict the protein component. Otherwise, normal protein intake, normal fat intake with carbohydrates of low glycemic index, and the way you communicate to him, because it has to be made comfortable for the person. Otherwise, he's gonna cheat, and therefore you would never come to know the real picture. Now, assuming the fact that you've done both diet control and exercise in a person and still glycosylated hemoglobin after 3 months is not getting controlled, what would you do? That is when oral hypoglycemic drugs should be introduced in the person. Please remember the fact that if HbA1c of a newly diagnosed diabetic type 2 person is more than 10% or equal to 10%, your advice would be first to start the person directly on insulin. Most people will freak out on that. Most people hate injections. Person will say, no, sir, I'm not interested in that. In those circumstances, you definitely can, start with oral hypoglycemic drugs and in the next consultation again reinforce the fact. But here in the exam, because they love to ask regarding the ideal guidelines, so oral hypoglycemic drugs are going to be started in a newly diagnosed case of type 2 diabetes mellitus with HbA1c ranging to be anything between 8 to 10%, and my objective is to bring it down to 7%. I've highlighted that to you earlier also, and I'm speaking about that again. What do you mean by the word good sugar control? And what do you mean by the word bad sugar control? Good sugar control will be glycosylated hemoglobin values less than 7, and if it's more than 7, I will say it is poor. I need to downgrade this. And to downgrade this, I have various drugs at my disposal. One of them is gonna be metformin, which is very commonly used, and you would have prescribed it to so many of your patients. The biguanides are the ones which are recommended, and the main mechanism of action of biguanides will be that they will inhibit hepatic gluconeogenesis. Once the production of sugar is hampered, then gradually HbA1c of the person will begin to fall. In the exam, he has asked, by how many percentage points will HbA1c start falling in the body of the person? Then the magnitude to be answered by you is 2%. Over the next 3 to 6 months, metformin alone can definitely reduce the HbA1c values of this person to respectable ones. The problem is mainly with compliance. Most Indian patients, they will avoid medication. They might say various reasons. They might say, I want to use Ayurveda, I want to use Baba Ramdev's medicine and stuff like that. But at the same time, if you convince him, then he is bound to listen. The tablets of metformin might be ranging from 500 milligram to 850 milligram to 1 gram tablets. The sustained release tablets are also available. Obviously, 1 gram for heavyweight patients of yours. What is the maximum dose of metformin that you can use per day? So that can go up to as much as 2.5 grams per day. Now, whenever you're giving metformin to the person, you need to keep a watch on the kidney function test of the patient, because this medicine is excreted via the kidneys. Please appreciate, metformin is excreted via the kidneys. Therefore, if the kidneys are malfunctioning, and still you are giving metformin to the person, the complication that can develop in the patient is lactic acidosis. I would like to highlight that a cousin drug of metformin by the name of fenformin was banned years ago. Fenformin was banned years ago because of the complication lactic acidosis. Fenformin was causing lactic acidosis even with normal kidney function. I repeat the statement again. Fenformin was causing lactic acidosis even with normal kidney function, but metformin will cause lactic acidosis only if the kidney is hampered. Now, when should you stop metformin? You are supposed to estimate the glomerular filtration rate of the patient, that is EGFR. There are various formulas available for it that I've discussed in the kidney section. If the estimated GFR of the person falls below 30, it's actually a range 30 to 45. If the GFR of this person starts falling to less than 30, then the chances of this person developing lactic acidosis will dramatically increase. Please appreciate the fact that if you are using the older version of the app, or you are using, rather, I would say, notes of the last year, I had highlighted the fact that if serum creatinine is more than 1.5 milligram percent, avoid metformin. This recommendation is still very much there, but in the exam, if they are giving both of these and you need to select the single best response, then estimated GFR less than 30 is a contraindication for continuing metformin. Why is it a contraindication? Because it can trigger development of lactic acidosis. So I reiterate the statement, fenformin was banned directly because it was causing lactic acidosis, but with metformin, if they ask you the side effects, most doctors casually answer lactic acidosis right away. I have explained to you that lactic acidosis will only occur if there is a negligence on the part of the doctor. In fact, there have been court cases against doctors, reputed ones, diabetologists. They continued giving metformin to the person. EGFR was falling because, well, they did not even bother to get a KFT done, or even if the patient had a KFT report, they missed it. So always be very, very careful about the kidney function test of a person report of a diabetic person, especially when you're giving metformin, because if the creatinine is spiking, it means that you need to stop metformin, switch to insulin. One of the biggest side effects with metformin can be standard GI disturbances in the form of nausea and vomiting, then can be B12 deficiency causing a macrocytic anemia, and then can be lactic acidosis developing in a person. What I say next is very important and very critical, so please listen to the next information with a lot of care. If the question simply says, what is the drug of choice for type 2 diabetes mellitus patient who is obese also? You are aware of the fact that metformin, in some books it is written as weight neutral, in some it is written it can help in weight loss. So I'll just put it like this. First information given in current medical diagnosis and treatment is that metformin is a weight neutral drug. However, in some other textbooks it is written as it is capable of causing weight loss. So I want you to remember both of these statements. It is weight neutral / contributes to weight loss, but insulin always causes weight gain. If you will give injections of insulin, then do remember the fact that people will tend to put on weight. Now, for a fat guy with type 2 diabetes mellitus, the drug that I will recommend will be metformin. But if I modulate the MCQ slightly, suppose I'm talking about this same chap, fat guy, type 2 diabetes mellitus, but I include the word nephropathy, then in those circumstances, I would not recommend giving metformin. So I have two options, either to switch to insulin or use oral hypoglycemic drugs which are metabolized by the liver. So in the exam, to test your pharmacology, he did not talk about insulin, but he talked about anti-diabetic drugs, or rather he talked about DPP-4 inhibitor, which is going to be metabolized by the liver, that is linagliptin. When this question that I'm putting the mark against right now, fat chap with kidney compromise, was asked when I was a student at your age, then we did not have linagliptin available. So at my age, I used to answer rather regarding glipizide. You will notice the fact that glipizide also has an alphabet L here, which sensitizes you to the fact that this is going to be metabolized by the liver. Additional drug, just from pharmacological perspective, that you can remember here is tolbutamide. I have just now reinforced your pharmacology by reminding you regarding 3 anti-diabetic drugs which are metabolized by the liver, that is linagliptin, glipizide and tolbutamide. And yeah, obviously if we can't use them, we definitely will be more comfortable using insulin, but a lot of patients might make a big face when you straight away starting or initiate insulin. So that's why the oral hypoglycemic drug component is also to be remembered. One of the important aspects that I want you to remember at this junction is what I've highlighted in red. Fat chap, type 2 diabetes mellitus, okay, metformin. But if it's going to be having a nephropathy, then don't answer metformin because of the risk of lactic acidosis. That brings us to the next important point of the discussion. That is regarding the subtypes of lactic acidosis. Well, if you go through the section on arterial blood gas analysis, if you go through the kidney and electrolytes part, I've talked about lactic acidosis. But I would like to highlight that statement once again, especially about when they will love to ask you regarding type A lactic acidosis versus type B lactic acidosis. Please appreciate type A lactic acidosis is due to underperfusion of the tissues. If a person has gone into circulatory failure, if a person has gone into shock, then the cells will switch to anaerobic mode of respiration. If the cells will switch to anaerobic mode of respiration, they will start producing lactic acid, and that lactic acid will be contributing to type A lactic acidosis. So if a diabetes mellitus patient ended up with, let me say, a pneumonia, then started developing sepsis and went into septic shock requiring vasopressor support, if he specifies that a diabetes mellitus patient had an infection, it could be UTI, it could be pneumonia. Once he has an infection, he ends up with sepsis, ends up with septic shock. The word shock should be there, or a low blood pressure value, or requirement of inotropes should be mentioned like dopamine, dobutamine, norepinephrine. Then it is type A lactic acidosis. But suppose in the exam, he just says what kind of lactic acidosis can be seen in persons of diabetes mellitus, and there is no mention of the word shock, under perfusion of tissues, vasopressor, then your answer will be type B. A lot of students listen to this casually and mess up in the MCQ. So remember, diabetes mellitus is capable of causing type B lactic acidosis. That is because diabetes mellitus is a silent killer. The kidneys would be hampered, and that can contribute to type B. I mean, this nomenclature is coming. A is mainly for people going into shock, anaerobic mode of respiration. Type B is due to medical disorders. So if he's gonna talk about drugs, metformin, fenformin, or is simply gonna write in the MCQ diabetes mellitus plain, then your answer would be type B lactic acidosis. He basically means, or he wants to see that, are you aware diabetes mellitus can cause a nephropathy, and thereby the chances of lactic acidosis increase, whereas with respect to type A, it's gonna be always septic shock. Well, lactic acid is excreted by the kidney, no? So if the kidney is compromised, it will not be able to do its job. Two important points that have been highlighted in this discussion are right here before your eyes. In fact, just to make you revise the information, I have highlighted to you that for reducing the microvascular complication in diabetes mellitus, it is HbA1c control. But to reduce the macrovascular complication, it is strict blood pressure control. And then these 2 points that are marked in red, I mean, these 3 domains that I've said, if you know about this, you know about diabetes mellitus. Though my words might sound a little harsh to you, but I just want to say that from a physician's perspective, if you answer these questions that I'm highlighted, it means that you know your stuff. Now, assuming the fact that you have already given metformin to the person, but HbA1c is not coming down. In those circumstances, you will be starting this person on sulfonylureas. Well, sulfonylureas have only one disadvantage, that they can contribute to hypoglycemic episodes. I'll teach you what can be done to prevent this from happening. But just to get you back on the track, remember we were discussing regarding oral hypoglycemic drugs, and 3A was usage of bigonides. So I am now discussing 3B, that is going to be usage of sulfonylureas. They are going to be introduced only when metformin has not been successful, and that is when sulfonylureas play a role. From the exam perspective, he can ask you that if I'm going to introduce sulfonylureas, what is the expected fall of glycosylated hemoglobin? It's going to be again in range of 2%. I'm not saying that combination of metformin and sulfonylurea will cause a 4% reduction, 2 plus 2. It's not mathematics here. All I'm saying is you start with metformin first. If it's not going to be successful, don't stop metformin. Continue metformin, add sulfonylureas. The advantage of this category is that the acceptability of the people is very good, because these drugs need to be taken only once per day, whereas metformin needs to be taken 2 to 3 times per day. Like I told you, 500 milligram tablet, maybe 3 times a day. So compliance is better in sulfonylureas. All of these drugs will begin with alphabet G for grease, that is glipizide, glyburide, gliclazide. So do remember these drug names from pharmacology. And as I highlighted, the only problem with these drugs can be hypoglycemia episodes. Now, why would hypoglycemia episode occur in a person? Well, usually the cause for this is that you have not sensitized the patient to the efficacy of this drug properly. Let us assume that we have an auto rickshaw driver who has been diagnosed with type 2 diabetes mellitus, and you have decided to start him on metformin plus glipizide. Metformin does not cause hypoglycemia, but these drugs have a propensity to contribute to hypoglycemia. Why? Because the mechanism of action of these drugs is like that one of the primary mechanisms of action of sulfonylurea is that they are insulinogenic. They will cause a burst of insulin or a spike of insulin in the body. In fact, here, your same intelligent patient can also quiz you that, okay, doctor, if this medicine will contribute to burst of insulin, what is the big deal? Insulin in my body is already elevated. So you would tell this smart guy that yes, I agree that it will cause an increase of insulin, but it will also increase the sensitivity of the receptor. So when it comes to sulfonylureas, they would act on 2 ways. One would be to increase the amount of insulin in the body, and second would be to increase the sensitivity of the receptors. Please appreciate the fact that if these two actions are done, then definitely the HbA1c values would come down. But as I was talking about a auto rickshaw driver, now this guy he ate the tablet of glipizide right now. And just now a passenger also came and he says that, okay, I have to go to this place that will be 10 kilometers away. So he ate the tablet, but now he's driving the auto rickshaw, so he can't have his food. Maybe his wife packed him his breakfast and lunch also, but he will not have time to eat that food because he has to carry the passenger. He has to drive an auto rickshaw. So during or on the transit journey, he can start developing hypoglycemic episode. So all you need to tell to the patient at this point of time is mealtime regulation. What I'm saying by mealtime regulation is that if a person has eaten the tablet, then the effect will start coming 15-20 minutes. So he should finish his meal by that particular point of time so that hypoglycemic episodes will never occur. So what I personally have seen is that if you educate the person properly regarding mealtime regulation, then there is no problem. Otherwise, very educated people also, like I have had patients who would be like, let me say, working in a call center, and they speak very good English. I explained everything to them. They did not listen to me carefully. And this guy, he ate the tablet of glipizide, and then he had a customer call in USA. And he's on the phone continuously for 1 hour. So obviously he did not have his meal because it would not look good talking to his international client while eating something. So the medicine will start having its effect. The spike of insulin will cause hypoglycemia, and that's where the palpitations and the sweating and the sympathomimetic manifestations will start occurring in a person. So multiple choice question 1, remember that metformin does not contribute to hypoglycemia, but sulfonylureas definitely have a side effect of hypoglycemic episodes based on their mechanism of action, and this can definitely be circumvented or prevented with a regular regulation of meal times. Coming to the next category of drugs that we shall be using for this person of type 2 diabetes would be thiazolidinone. Let us quickly revise regarding the mechanism of action of these drugs and then the adverse effects, which are relatively more important. The main mechanism of action would be to increase the peripheral utilization of sugar, which basically means that it will increase the GLUT4 receptors on the surface of the muscle as well as the adipose tissue. Another advantage of this drug, over and above what I've written, is that it also reduces serum triglycerides, and that is good news because diabetic people will be usually having deranged lipid profile in the form of increased cholesterol and triglyceride that contributes to accelerated atherosclerosis. Thiazolidinones have been mentioned subsequently after metformin and sulfonylureas because the reduction of glycosylated hemoglobin with this category of drugs is to the tune of approximately 1%. So they are to be used as a backup and not as primary agents. The drugs which are available here are by the name of pioglitazone and rosiglitazone, and they again have a good acceptability from the patient's perspective. Why that is so is because both of these drugs need to be taken once a day or maximum twice a day, and people are more comfortable when lesser number of tablets is to be taken. So the advantage of these two drugs is the compliance component is good. Now we will study regarding the disadvantage, which is a big time problem. Both of these drugs have been studied to actually worsen cardiovascular mortality, not in all patients of diabetes, but especially the ones who are already having a pre-existing heart disease. Therefore, multiple choice question 1, if he talks about a diabetes mellitus patient, he says or mentions about the fact that this person already is suffering from chronic congestive heart failure, is taking treatment for congestive heart failure. The etiology for congestive heart failure can be manifold. One of the important causes is ischemia due to coronary artery disease. So in a known case of diabetes mellitus with congestive heart failure or coronary artery disease, your answer would be that this category of drugs is absolutely contraindicated. If ejection fraction is normal, if he has not had any cardiac event, coronary event, then fine, you can use this category. But if it is documented that there is already a heart failure in the person, then answer this drug category as contraindicated. A study from Chennai had also mentioned regarding another side effect of this drug, that is increases the incidence of bladder cancer. So two side effects are to be remembered: enhanced cardiovascular mortality and increased risk of bladder cancer with this category of drugs. Over and above this, I also have at my disposal alpha glucosidase inhibitors. Now, when I will speak about alpha glucosidase inhibitors, you will notice that I will always emphasize about these drugs being taken with meal. Normally, anti-diabetic drugs are taken before the meal, But in this particular case, alpha glucosidase inhibitor is gonna be taken with meal because the main objective behind developing this drug was to control the PP spike. You see, sugar will rise in your and my body also after eating food, but in a diabetic person, the spike will be much more sharper. We wanna prevent these postprandial spikes. That is why alpha glucosidase inhibitors have been developed. The mechanism of action of this category of drug is gonna be inhibition of gastrointestinal tract absorption of sugar. Well, the good news is that the person has had a high calorie meal with high glycemic index carbohydrates. But if you inhibit the GI absorption of sugar, then the PP spike can definitely be, if not prevented totally, at least it will become relatively flattened. The disadvantage of the drug, however, will be that sugar will not be absorbed. If sugar is not absorbed, it can contribute to a side effect of osmotic diarrhea. This explains why many patients will make a big face when they come back to you after intake of alpha glucosidase inhibitors. The drugs which are available here are like acarbose or voglibose or miglitol. Please remember the fact that acarbose, voglibose, miglitol, these are medicines which are going to contribute to side effect of diarrhea, and therefore the acceptance part on the part of the patients is limited, and the fall of HbA1c with this category of drug is 0.25%. Well, when I describe 0.25%, people tend to ask me, doctors tend to ask me, sir, if the HbA1c fall is so less, what was the need of doing so much of research and development and developing this drug? You see, this drug has not been designed for long-term control. This drug has not been designed for long-term control. This drug has been mainly designed to control the postprandial spikes in the person. So if it will act for relatively a shorter duration, its effectiveness in controlling HbA1c will be relatively lesser. But as they say, all small steps together result in a big project being done. So this is an additional drug that we are having against the problem of diabetes mellitus. As compared to acarbose, voglibose has a relatively lesser incidence of osmotic diarrhea. The next category of drugs that I'll explain to you will again help in controlling the postprandial spikes of the person, and the drug category name is meglinetide. Whenever you introduce a new category, the patient of yours, the educated one, will definitely love to know regarding the mechanism of action. You will explain to this patient that the main mechanism of action is that this is going to produce up insulin in the body. This drug has a insulinogenic action. The second action is it increases the sensitivity of the receptors, and when you explain this, then you definitely will have your same patient asking you that, sir, you told me the same thing in fact for sulfonylureas also. You see, if I go back in my slides, when I was explaining sulfonylureas to you, I had spoken regarding the fact that they have an insulinogenic action and they also enhance the sensitivity of the receptor, and now I have explained the same thing even for meglinetide category. So this very smart patient has caught me. He's saying, sir, you telling me the same thing. He says, what's the difference? And I can put that up as a question to you guys. I mean, sulfonylurea and meglinetide are having the same mechanism of action. So what was the name of mentioning it in pharmacology book as a separate category? Well, the reason for that being that sulfonylureas tend to have a long duration of action. Remember, I told you that glipizide can be taken once a day. Sulfonylureas have been designed for rather of one tablet for a whole day action, but this drug is to be taken with meals. It has been mainly designed for controlling the postprandial spikes. I highlight the fact once again that both acarbose, voglibose, that is belonging to alpha glucosidase inhibitors, and meglinetide molecules like repaglenide and nataglenide, they have been designed to keep in mind that postprandial spikes are also to be regulated. The advantage of these drugs would be that the sudden spike of sugar will also contribute to tissue damage. Then you see, you are to use a combination of these drugs. It could be metformin with 2 drugs, that is dual therapy. It could be metformin with 3 drugs, that's a triple therapy. But the point is, when you use a combination of drugs, you will be able to achieve better control of blood sugar in the body of this person. The next category of drugs that I'll explain to you is very frequently asked in the exam. So please listen to the mechanism of action very carefully. Suppose I'm giving intravenous 10 gram glucose to patient A, and to patient B, I'm giving oral 10 gram glucose. Both patients are being given 10 grams of glucose only, but the route of administration is different. It is no rocket science for anybody to understand that with the intravenous route, the blood sugar will spike faster. Whereas when you give the same amount of sugar orally, then the blood sugar will still rise, but it will rise relatively gradually. Though the final spike might be the same, but the rise will be gradual. So they did a study to find out what is it being produced by our intestinal cells. What is being produced by our enterocytes that is causing this gradual rise of sugar rather than a sudden rise? Because after all, the sugar is absorbed, so the rise should be the same, but it is a gradual rise. They found that our enterocytes, especially the cells by the name of L cells which are present in our ileum, they tend to produce a hormone by the name of GLP-1. Now, how does GLP-1 work? What I'm telling you is a hack. This is just to make pharmacology easy for you. You can remember GLP-1 as, mark my words there, this is just a hack. This is one of the methods of remembering how this molecule is acting. So GLP-1 you can remember from a hack perspective as glucose-linked insulinotropic peptide. Now, when you focus on the name insulinotropic, it basically means the fact that it is behaving like insulin. It's not insulin, it's behaving like insulin. This molecule is behaving like insulin. So what will it do? It will send sugar inside the muscles. It will send sugar into the muscles and the adipose tissue. And me as a physician is satisfied, because if sugar is going inside somewhere in the body of a diabetic person, I'm definitely happy. This GLP-1 molecule acts in the body for a limited duration of something in the range of 1 to 2 hours, after which it is disintegrated by an enzyme by the name of DPP-4. I repeat the facts once again. Once we eat sugar, our intestinal cells produce GLP-1, which behaves like insulin. It's not actually insulin. It sends sugar into the muscles and then it is degraded by DPP-4. I'll mention the full form of DPP-4 also. But at the moment, all I'm saying is that if I'm going to put brakes on this DPP-4, if I'm going to inhibit DPP-4, then the breakdown of this will be inhibited. That basically means that GLP-1 will now be able to act for longer duration, and if it will act for longer duration, then it will cause more sugar to go into the muscle, and therefore the glycemic control will be relatively better. So the category that I'm talking about here is dipeptidyl peptidase 4 inhibitor. DPP-4 inhibitor is dipeptidyl peptidase 4 inhibitor. The main mechanism of action of this drug is it inhibits the breakdown of GLP-1, and the good news is now the sugar will be having an opportunity to enter into the muscle for a relatively longer duration. In fact, these drugs are extensively used in clinical practice nowadays. The molecules would be like sitagliptin or would be like linagliptin, and I've already sensitized you to the fact that linagliptin begins with alphabet L. It is metabolized by the liver. So if a person's kidney is getting compromised, then I'll not give sitagliptin, I'll give linagliptin to the patient because it is metabolized by the liver. Well, once we got success with DPP-4 inhibitors, we did some more study on these L cells which are present in our ileum. So keep the focus on. What they found is that we do have drugs or capacity to develop drugs which can stimulate these cells in the ileum. We are now having drugs which would be called as incretins. Now look at the statement that I make. What incretins is gonna do is that they are gonna stimulate these L cells to produce more GLP-1. So you need to understand the difference between the mechanism of action of DPP-4 inhibitor versus the incretins. The mechanism of action of incretin is rather hidden in the name itself. Incretin basically means increase. So it will increase the production of GLP-1 by causing stimulation of the L cells. Whereas when it comes to DPP-4 inhibitor, it's going to inhibit the breakdown. The molecules which are available here are in the form of injectables. That's slightly a disadvantage. Exenatide and liraglutide are injectable molecules which are gonna help in increasing the value of GLP-1 and thereby send sugar into the muscle. In fact, because they are injectable, they were not very well received in the Indian market because Indian patients basically want oral drugs. Therefore, the Americans had to do more research and development and they modified exenatide. In fact, as of now, exenatide is available as once a week injection. Now, because exenatide is available as once a week injection, that definitely is very, very commendable in this field of diabetology, in a sense that the compliance part will dramatically rise. However, there is also a side effect. This side effect is very rare but is deliberately asked in pharmacology. The question asked was, which anti-diabetic drug has a tendency to cause hemorrhagic pancreatitis? You're all aware of hemorrhagic cystitis being caused by cyclophosphamide. Never an issue, but hemorrhagic pancreatitis is caused by exenatide. That's a new molecule developed as once a week injection. Do remember the fact that now we are also having once a week insulin also. Now this might look like a surprising statement from me to you, but then yes, we are in the phase of development of even once a week insulin, because when I was talking about types of insulin, I just spoke about the CSI-IF part, or I spoke regarding the routes of administration, but I did not talk about once a week insulin because this is a relatively new development. In fact, this once a week insulin is called as insulin icodec. It's written as insulin isodec, and once it comes into main production, the treatment of diabetes will dramatically change, and the acceptability part on the part of the patients towards insulin will also rise. But this is a new development, so this is optional for you if you want to remember or not. Whatever is written on the board in color blue at the moment is a must-know information. The category that I'm gonna explain next to you after this, the category that I'll be explaining to you next would be the one that will be acting on the kidney. Let us take this as the representation of the glomerulus. This is the afferent and the efferent arteriole, and this is the proximal convoluted tubule. Present in the proximal convoluted tubule are some transporters which are called as SGLT2. The main function of SGLT2 will be reabsorption of salt. Obviously, along with that, water will also come and sugar will also come. So SGLT2 basically helps in reabsorption of salt as well as water. All they did was they blocked this. If you block SGLT2, what's going to happen is that it will promote the urinary loss of salt as well as the urinary loss of sugar. And in a diabetic person, if I'm losing sugar from the body, I'm happy. The mechanism of action of SGLT2 inhibitors is that they promote urinary loss of sugar. And well, this is advantageous in a diabetic because blood sugar is grossly elevated, so loss in any form is welcome. However, there is a side effect that would come up here also. Well, what is the side effect? If you are going to lose sugar in the urine, then higher sugar in the urine would mean that it will increase the risk of UTI also. This is itself a multiple choice question, that which anti-diabetic drug increases the UTI risk, that is SGLT2 inhibitor, though this can be prevented also. And how would you prevent it? By increased water intake. Now we will talk about the advantage of this molecule. The advantage is rather very, I would say, dramatic in this particular field, because SGLT2 inhibitors have been shown to reduce cardiovascular mortality, and now they have come up in the hierarchy of anti-diabetic drugs. After metformin, you will see every physician prescribing SGLT2 inhibitors. Primarily, why? Because they decrease cardiovascular mortality. You need to remember the fact that cardiovascular mortality is increased with drugs like pioglitazone or rosiglitazone, as I have highlighted earlier, but with SGLT2 inhibitors, the cardiovascular mortality will be significantly reduced. There are many SGLT2 inhibitors available in the market, but the one that is I have found commonly being asked in the exam is canagliflozin. So you need to basically remember these anti-diabetic drugs that I made you brush up once again, and the main objective of these drugs is, one, to achieve a long-term control, and then to achieve control of postprandial spikes, and a combination of these drugs will definitely do very good for management of our patients. Hence, from pharmacology perspective, what they've asked in your exam is which anti-diabetic drugs are useful in both type 1 and type 2 diabetes. Now, obviously, insulin is useful for both type 1 and type 2 diabetes mellitus. As I've explained to you, it will be mainly used in type 2 diabetes either towards the end, or it can be started initially also when there is a poor glycemic control and HbA1c is more than 10%. In the exam, apart from insulin, you need to remember that even acarbose, the one that I was talking about, controls the PP spikes and has to be taken with meal per se, is also useful in both type 1 and type 2 diabetes mellitus, but this is off-label. In the exam, if he says per se single best response, which drug is useful both in type 1 as well as type 2 diabetes mellitus, then from pharmacology you should be aware regarding pramlintide. Though all three are answers to this question, the single best response would be given as pramlintide. When it comes to management of patients of type 2 diabetes mellitus, the current guidelines are in the following format. In case you find that the HbA1c of the patient is about 8%, so I'll just go by percentage values here. If HbA1c of a person is less than 9%, then what is recommended is monotherapy. We can be having a dual therapy, a triple therapy, and even a combination therapy. But these are the guidelines as of now. Please remember the fact that if HbA1c is less than 9%, obviously more than 6.5, then what is advisable for this person is combination of lifestyle modification plus metformin. However, on follow-up in the same patient, or it's a newly diagnosed case, let me say, the HbA1c of the person is more than 9%, that is in a range of 9 to 10. Then the guidelines are to go in for dual therapy. Dual therapy would mean most of the time, most physicians will be giving combination of metformin plus SGLT2 inhibitor. Obviously, the cost part is also to be considered. If somebody cannot afford the expensive medicines, that is SGLT2, because they're relatively new, then you can definitely use glipizide or gliclazide or sulfonylureas, which are relatively cheap. In fact, you can make it triple therapy also. Traditionally, you read about triple therapy with respect to H. pylori, but I'm talking about triple therapy in type 2 diabetes, which means 3 anti-diabetic drugs have been combined in a person, like metformin, SGLT2 inhibitor, and acarbose. But if you come across a patient whose HbA1c is more than 10%, then what they recommend is called as combination therapy. What I mean by the word combination therapy is that here it will be insulin with metformin. So remember my words very carefully. And yes, you can give insulin metformin together also. And metformin does not cause hypoglycemia. Remember, it is sulfonylureas which contribute to hypoglycemia. I'm writing plus minus. You can give SGLT2 inhibitors also if required. So these are the guidelines which are currently available. In fact, these are the latest ones which are recommended: monotherapy versus dual triple therapy versus combination therapy. The minimum carry home message that I want you to take home from this is, if a newly diagnosed case HbA1c is more than 10%, straight away start with insulin plus another drug. That's a separate issue, that if the acceptability part is not there, then obviously you can't do much and you will have to start with a dual or a triple therapy for the person. Let us also remember regarding the usage of insulin, though I've highlighted this part earlier also, but I'm speaking about it once again. Insulin is useful for type 1 diabetes mellitus on a lifelong basis, will be required in 1.5 diabetes and even in type 2 diabetes mellitus, which might have become refractory to all the standard oral hypoglycemic drugs. And in the later stages of type 2 diabetes, as I've highlighted to you, there will be beta cell exhaustion. So now sulfonylureas will stop working, and that is where the role of insulin will come. So insulinopenia can be found in all the standard 3 types of diabetes. Apart from this, insulin has also been discussed in management of acute hyperkalemia. In the cardiology section, I have spoken regarding ECG findings of hyper and hypokalemia, and that is where insulin drip has been discussed. Even in complications like diabetic ketoacidosis, complications like non-ketotic hyperosmolar coma. In fact, non-ketotic hyperosmolar coma is more common in type 2, whereas diabetic ketoacidosis is more common in type 1. I'm not saying that ketoacidosis will occur only in type 1. It can occur in type 2 also, but is relatively more common in type 1, and non-ketotic hyperosmolar coma is more common in type 2 diabetes mellitus. When it comes to emergency, when it comes to intravenous regular insulin, then we are gonna be using it for the following 3 indications, that is acute hyperkalemia, DKA, and non-ketotic hyperosmolar coma. I will now be explaining to you regarding the rarest form of diabetes, that is called as MODY. You see, the commonest type of diabetes that we come across is type 2 diabetes, and this is gonna be the rarest variety, majority onset diabetes in young people. There are actually 6 varieties of this, out of which the commonest one is MODY3. So let's study regarding what is this disease all about. Well, the pattern of inheritance of this disease is autosomal dominant. The peak age of onset of MODY is approximately 25 years of age, and because it is autosomal dominant, it will be expressed in almost every generation. Most of the time when the diagnosis is made, the patients are asymptomatic. I mean, this chap, he's, let me say, an engineering graduate, and he's completed his engineering and now is getting a job in a multinational company. So this multinational company sent him the performa for getting his basic medical checkup done before he joins duty. In that basic medical checkup, his blood sugar came to be grossly elevated. So this young chap, 25 years of age, asymptomatic, he thought it is an error on the part of the laboratory. He called up the lab. The lab said, no, sir, the report is correct. So he got the test done from a different lab. And even there, the blood sugar is turning out to be, let me say, 200 milligram percent fasting. When he came to me, he says, Doc, I don't have any problems. I had just applied for a job. I got that job. And in the pre-employment screening, the medical checkup showed my blood sugar is high. Am I a diabetic? And when you talk about this person's family history, yes, you will find, because the disease is autosomal dominant. So his father may be a diabetic. He might say, my father is a diabetic. My father's younger brother, that is his chacha, is also a diabetic. And even his grandfather was diabetic. He says, I never saw my grandfather. He died maybe because of sudden cardiac death and silent MI. As I've explained earlier, in diabetic neuropathy, they can be silent MI. So he says, I've never seen my grandfather. He died suddenly. He was a diabetic. My father is a diabetic. My bua is a diabetic. My chacha is a diabetic. So diabetes is running in family, because the pattern of inheritance of autosomal dominant ensures that the disease is expressed in every generation. I would just like to reiterate that there are a total of 6 types of MODY, out of which the commonest one in India and America is MODY3. They've asked in the exam which chromosome is involved here, so that would be chromosome number 12. They've asked which gene is involved, your answer would be HNF1 alpha gene. And the genetics is something that is an unending job. So whenever you read about gene or a chromosome, I would like you to note it down separately, so that you have a ready reckoner where all the diseases, different genes and chromosomes can be remembered from a single sheet of paper. Coming back to the agenda, guys, what I'm explaining to you at the moment is one of the rarest form of diabetes, that is MODY. This condition is also characterized by having a insulinopenia. And the common query that I get from a lot of young doctors is that if this has insulinopenia, then how is it not different from type 1 diabetes? So listen to the difference very carefully. In type 1 diabetes mellitus, beta cells are destroyed. But in MODY, the surprising thing is beta cell mass is normal. It is because of defective genes that the production of insulin is still hampered. You see, there can be 2 reasons why insulin is not getting produced. One reason can be beta cells are gone. Second is beta cells are okay, mass is okay, number is okay, but the problem is still with the processes which are involved in synthesis of insulin. You see, there are series of enzymatic reactions that will ultimately produce insulin. So if these reactions are defective, still the amount produced will be lesser. I repeat that fact. One problem why insulin production can be less is because beta cells are gone. Second is beta cells are there, no problem. The number of beta cells is still okay. There's nothing destroying them, but still, because they're not functioning optimally. So you can remember MODY as a condition of suboptimal insulin production. The highlight of this disease is, as I explained, almost every generation in this person would be involved. We need to understand and compare MODY with type 2 diabetes, because in type 2 diabetes mellitus also family history is involved. This is a 25-year-old guy. He has been diagnosed as suffering from diabetes mellitus by me because his fasting blood sugar was elevated. He does not have any symptoms. HbA1c is more than 6.5%. His father is also a diabetic. His grandfather is also a diabetic. In fact, his father's younger brother and maybe elder sister is also a diabetic. In contrast, when it comes to type 2 diabetes mellitus, you might have a 40-year-old person who's diabetic. He says that my father was not diabetic, he's perfectly fine. His brother, elder brother or younger brother is normal. His sister is also normal. They're not having diabetes, but my grandfather had died from diabetes mellitus. You can see that in one of these discussions, I have skipped a generation. In MODY, there is no skipping of generation. Almost consecutively, 3 generations have been serially involved. But in type 2 diabetes mellitus, there can be skipping of generations also. Please appreciate the fact that this is only clinical, in a sense that I, by looking at a person, can't say it is type 2 or it is MODY, simply because of the fact that the physical appearance does not tell you regarding the type of diabetes. If I want to be 100% sure, what will I do? I can do a radio immunoassay insulin level. If I do a RIA, a radio immunoassay fasting insulin level, in a case of MODY, I will find it will be lesser. But in type 2 diabetes mellitus, as I've explained to you, receptor problems, so the values of this would be elevated. However, clinically, I am very sure you would have come across patients where they will say, everybody in my family is having diabetes. That is where you suspect MODY. On the other hand, if there's skipping of generations, it's definitely a possibility of type 2 diabetes mellitus. Why am I emphasizing this is because in our medical college, it is emphasized that family history is important for type 2, agreed. But family history is all the way more important for even MODY as well, which happens to be the rarest type of diabetes. Let us just summarize the facts that I've told you. I would like you to make this table with me, and you should be able to complete the table in as little a time frame, preferably under about 1.5 to 2 minutes, because current scenario of the exam not only requires accuracy, but it also requires speed. Well, there are 4 types of diabetes that I have explained to you today. That would be type 1, type 2, then 1.5 and MODY. We will first talk about what happens to radio immunoassay insulin levels in this person. Then we'll compare what happens to beta cell mass in these patients. I hope you recall that in MODY, the beta cell mass is not affected. The beta cells are fine, but still there is a suboptimal production. Then we will talk about why is it happening. And lastly, we will study regarding what can be done as first line for these patients. In type 1 diabetes mellitus, insulin is lesser. In type 2, it is elevated. In later stages, there is a beta cell exhaustion contributing to a reduction. 1.5 is also less, MODY is also less. So insulinopenia is found in all forms of diabetes ultimately. In type 1 diabetes mellitus, beta cell mass is reduced due to autoimmunity, but beta cell mass is normal in MODY. When it comes to type 2 diabetes mellitus, the main problem in this person is primarily with respect to the receptors. So again, beta cell mass is normal. I'm then writing the word exhaustion. I hope you recall that in type 2 diabetes mellitus, in the later stages, they can definitely be exhaustion occurring. In 1.5, it is again autoimmunity contributing to reduce beta cell mass. Now, why is it happening? For type 1 diabetes, you will answer autoimmune. 1.5 is also autoimmune, but I'll just make you remember the autoantibody involved here. There were 2 of them, but I'm writing name of only one, anti-GAD. The second one was anti-islet cell antibody. For type 2 diabetes mellitus, we were blaming defective genes. We were saying that there is a positive family history, but family history is all the way more important for even though autosomal dominant varieties of the 6 types of MODY, out of which the commonest variety is MODY3 and chromosome 12 is the one which you can remember is responsible. When they talk about the treatment part for treatment of type 1 diabetes mellitus, the first line treatment that you'll offer to the patient right away will be insulin. I have explained to you that now even once a week insulin is available. Then once a week drug that I taught you was injectable exenatide. But then we need to give standard insulin to this person, a combination of basal as well as the prandial insulins, so that we can achieve good glycemic control. For type 2 diabetes mellitus, after lifestyle modification, we have to start with metformin. The decision will be based on the values of HbA1c. If the values of HbA1c is more than 10%, recommendations are start with insulin plus metformin. For type 1.5 diabetes, we will start the person on glipizide, sulfonylureas. Why? Because you can spike the production of insulin, and even in MODY, we will start the treatment with sulfonylureas. So this is itself a question that in which form of diabetes would you prefer starting with sulfonylureas? Your answer is 1.5 diabetes and MODY, which are relatively less common. That is where we start with sulfonylureas. I've already sensitized you to the fact that the most common variety of diabetes encountered is type 2. And the rarest variety out of all of these encountered happens to be MODY. And if they simply ask you which complication of diabetes is overall the most common, it could be mentioning regarding neuropathy, nephropathy, retinopathy, then 50% cases of diabetes would be ending up with a diabetic neuropathy if they do not take care of their health. In fact, a random statement of mine will emphasize for you why treatment is important, because if you will ensure compliance, you can add as much as 15 years. You can add as much as 15 years to the lifespan of this person. You add a huge number of years to a lifespan of I mean, obviously the lifespan will be proportional to whatever is the expectation in the country, but you're adding years to a life of a diabetic person by simply ensuring compliance. So the way you communicate to him regarding the usage of drugs is of paramount importance. I shall now be explaining to you regarding the long-term complications of diabetes mellitus. The first and the foremost on the agenda would be to speak regarding diabetic retinopathy. You are familiar with the fact that these patients can be having 25 times higher chances of going blind. So we are going to study about what can be done to prevent this from happening. First and foremost, why would retinopathy develop? Well, that would be due to uncontrolled diabetes mellitus. Not every diabetic would be having risk of retinopathy. It's a person who is having HB1C more than 7%. In these circumstances, in type 1 diabetes mellitus, it will take approximately 5 years, whereas in type 2 diabetes, it will take approximately 15 to 20 years. If you have to answer single best response, your answer would be given as 20 years for type 2 diabetes mellitus. Well, one of the most important determinant for developed retinopathy is duration, and after duration, the second most important thing is the level of glycemic control. Now, because we know that this will happen, you also have to be familiar with the fact that retinopathy and diabetic nephropathy develop with almost the same speed. The time it takes for nephropathy is against 5 years for type 1 and 20 years for type 2. So they have asked in the exam, what are the markers or tests which can help you identify retinopathy? Now the first impression or the thought process of every student will be that when he will talk about retinopathy, he will give you some fundus findings, but surprisingly in the exam, he did not give any fundus findings. Rather, he asked a blood test that can help you identify that this person is having a diabetic retinopathy. Because retinopathy, nephropathy go with the same speed, so one of the tests that you can use to monitor the progression of retinopathy is serum creatinine. Well, let me get you the perspective right. If a diabetic person is having problem in his eyes, that means his kidneys are also to be scanned. In a person whose kidneys are involved, eyes are always to be scanned because both organ progression or damage occurs at the same speed. You can definitely check for serum creatinine. If it is elevated, that means kidneys are involved and simultaneously the eyes of the person would also be involved. But the problem with creatinine is that it rises relatively late. So instead of serum creatinine, there is an alternative test we can use to our advantage, that is serum creatinine is obviously a very specific test, but it is not sensitive enough. So a test that is sensitive enough as compared to serum creatinine is creatinine clearance. So either of the two can be used. I highlight once again, serum creatinine happens to be the most specific kidney function test, but it is not sensitive. So for sensitivity, I can definitely go in for creatinine clearance, which can be calculated by various methods. Over and above this, I can also check for albumin excretion rate. You see, when I was a student your age, we always used to study regarding the terminology by the name of microalbuminuria. But currently Harrison has stopped using the term microalbuminuria and is rather talking about albumin excretion rate, in which the numerator will be talking about the amount of albumin in the urine, which can be in the range of 30 to 300 milligram. But in the denominator, it's not gonna be per day. In the denominator, it is gonna be per gram of urinary creatinine. I repeat once again, in the numerator it is albumin, that is 30 to 300 milligrams of albumin, or it can be higher than that also, but in the denominator it is not per day, it is per gram of urinary creatinine. I'll just use a short form. UC would imply urinary creatinine in this case. However, in a multiple choice question, if he says what is the best way to monitor diabetic retinopathy, as I emphasized to you, I would definitely love to give our answer from the findings found in the fundus examination. But if fundus findings are not given, then your first answer is homocysteine levels, then is creatinine clearance, then can be albumin excretion rate. I mean, all three are obviously the correct answers to this question, but then the way I put this arrow is for selecting the preference for the single best answer. From the fundus perspective, if they ask you what is the earliest fundus finding of diabetic retinopathy, your answer would be microaneurysm. In fact, they've gone even more deeper. They have said in which of the 10 layers of the retina microaneurysm would be located. You are aware of this, that this would be located in inner nuclear layer, and the mnemonic to remember this is MAIN, main. MA would stand for microaneurysm, and from alphabet IN, you can remember that this would be inner nuclear layer. This is always asked in the exam. Whenever they ask you fundus finding like cotton wool spots, or if they ask you regarding microaneurysms, which is one of the early finding, they'll always ask you which layer would it be found, and the options would be like inner nuclear, outer nuclear, inner plexiform, outer plexiform. So you need to remember it is the inner nuclear layer that is usually involved. Now, as the disease will progress, the person can go into a non-proliferative or can go into a proliferative retinopathy. In the exam, he has asked regarding the finding of non-proliferative retinopathy. I know the fact that you are familiar with all this from ophthalmology, but I would like to do my part here. The non-proliferative retinopathy will contribute to macular edema, and because of this macular edema, there's a distinct possibility that this person will be having a visual loss. please appreciate the fact that there is one hell of a difference between the word blindness versus a visual loss. So if he says what causes a blindness in a diabetic, it is a proliferative retinopathy, it's a retinal detachment or a vitreous hemorrhage. But if he specifies the word visual loss, what is the reason for visual loss in a diabetic? Your first answer would be macular edema. Let us compare this with what is the standard presentation of proliferative retinopathy. Well, the bad news is this person can go blind. So once this happens, we are obviously very concerned about the person. Proliferative retinopathy occurs because of neovascularization, and extra blood vessels can contribute to load on the retina and retinal detachment can occur. Neovascularization can contribute to two problems. One can be that any of these vessels can bleed and can contribute to opacity in a normally transparent vitreous, so vitreous hemorrhage. And second can be definitely a problem of retinal detachment. Now, as they say, prevention is better than cure. Prevention is better than cure. So had you kept HbA1c less than 7%, none of this would have ever occurred. But now, because it has occurred, what can I do? What can I do to prevent the onset of subsequent blindness in this person? I can use a laser beam. I can use the heat of the laser beam to fry up these blood vessels, and therefore, if neovascularization has already occurred, I need to be more aggressive. You are aware from ophthalmology that we will go in for pan-retinal photocoagulation. Along with this pan-retinal photocoagulation, we will also be giving some intravitreal injections. The reason why we give intravitreal injections is to prevent the development of new blood vessels, but the ones that are already there, I need to fry them up, I need to burn them up. So for pan-retinal photocoagulation, we shall be using here is a ND-YAG laser. The heat of the laser beam will contribute to the burning of the blood vessels. In a single setting, not only a pan-retinal photocoagulation is done, but along with this, injections of bevacizumab are also given. You are familiar that bevacizumab is an anti-vascular endothelial growth factor. So I'm doing two things together. I'm taking care of the abnormal blood vessels and I'm preventing them from occurring as well. Repeating once again, what is the best way to prevent blindness in a diabetic patient? The first method would be good blood sugar control, which would be defined as HbA1c less than 7%. Then would be PRP, and then would be the aspect of bevacizumab. Obviously, when he will give you questions where multiple responses are correct, all three will be given. For single best response, your answer would be HbA1c levels less than 7%. As I highlighted, prevention is better than cure. Otherwise, this person has had it. The incidence of blindness in diabetic population is 25 times more. In fact, the incidence of gangrene in a diabetic person can be as much as 100 times more. The most peculiar thing that I have taught you in diabetic retinopathy is rather markers for progression of this retinopathy. Because traditionally speaking, whenever we study about retinopathy, we are always thinking about fundus findings that he's expecting us to answer. But on the contrary, he's asking you regarding the blood tests that can be done, and the first answer would be serum homocysteine. As far as the findings are concerned, in the later stages, you would have myriad manifestations in the form of cotton wool spot, but cotton wool spot is not specific because cotton wool spots can be seen in HIV positive person also. Cotton wool spots can be seen even with hypertension patient also. So it is microaneurysms, and then a proliferative retinopathy that will cause bleeds is one of the highlights of the disease, and we need to prevent it from happening. Another aspect that I would like to highlight once again for diabetic retinopathy is that if he uses in the MCQ the word visual loss versus that of blindness, visual loss, the answer is going to be given by you as macular edema, as I've explained here. But if he specifies the word blindness, then obviously the proliferative retinopathy component will come into picture. The next complication that is found in diabetes mellitus patients is diabetic neuropathy. The incidence of this is 50% of all patients of uncontrolled diabetes, that is HbA1c more than 7%. So this will take the numero uno, or the most common presentation. Out of the sensory versus motor versus autonomic, if they ask you to select one, first sensory involvement occurs, then would be motor involvement, and lastly it is the autonomic manifestations that would occur in the person. In sensory, if he says what is early affected, your answer would be that the person can develop distal sensory loss. When it comes to the various type of sensations, it could be fine touch, crude touch, vibrations. Then if he says what is first to be lost, then remember in the sensory loss, if he says first to be lost is, then the answer is vibration sense. He can also go a step further and say which tuning fork would be used here to evaluate the vibration sense loss in this person. Your answer would be the tuning fork with frequency of 128 Hz. Do remember the fact that in diabetes mellitus, all fibers can be affected, large fibers, small fibers, but this disease has a predilection to mainly affect the ultra small fibers, that is the unmyelinated C fibers. Now, because of this small fibers getting involved, multiple choice question will use the word small fiber neuropathy. This is itself an important question to be remembered because small fiber neuropathy is usually asked for one HIV and second diabetes mellitus that we're discussing right now. Because of this unmyelinated C fiber involvement, in fact, these patients can be having development of pain. This pain could be present in the soles of the patient as well. So lot of diabetic patients might actually, one, say to you that they may not be able to feel their shoes in their feet. That is one. Second, at night when they're sleeping, they might be feeling pain in the soles. This will disturb the sleep of this person. So they've also asked what will be the best drug to manage this diabetic person who's complaining of pain in the soles, especially at night, and therefore has a disturbed night. Though you can use multiple drugs for these patients ranging from gabapentin to pregabalin, if they ask you to select one, your first answer would be duloxetine. Then obviously you can answer pregabalin or even gabapentin can be used in these patients. And in some cases, we might even be using combination of these drugs, including usage of amitriptyline. Now, once we have talked about the sensory manifestations, he can definitely ask you regarding the motor manifestations of this person. From the motor manifestation profile, remember that he'll ask you regarding which cranial nerve is usually involved. Remember, it is third cranial nerve which is most commonly involved in diabetic neuropathy. And because of this third cranial nerve involvement, definitely in the person, there can be development of ptosis. Please remember the fact that when this third nerve is involved in the person, the deeper fibers that control the pupils are not involved. In fact, this was one of the questions in previous NEET exams. So the manifestations can definitely be in the form of a unilateral or a bilateral ptosis. You could even be having squint because of the imbalance between the muscles of the third and the sixth nerve now. But because of the pupillary sparing, the light reflex of the patient will definitely be preserved. Do remember the statement of mine, third nerve palsy with pupillary sparing is a feature that is seen in diabetic neuropathy. I'll explain to you some other conditions also in neurology where I have said this term third nerve palsy with pupillary sparing, but let us just complete the autonomic profile of this person as well. From the autonomic profile perspective, one of the important things that you need to understand and remember is that these people could be having recurrent falls. Now, why are they having recurrent falls is not because of loss of sensation in the sole of the foot. A lot of these patients may be actually saying that I have purchased special shoes to increase the traction on the ground. So it's not that my foot slipped on the ground and I fell. I just fell as if my head was spinning and then I fell down. I said, what really happened? He says, sir, I just got up from the bed and my head was spinning and I suddenly fell down. So a lot of diabetics can actually be having a combination of these findings also. That is, diabetic neuropathy can definitely contribute to increasing the chances of fall. But this chap is giving you a very peculiar history. He's saying whenever I get up, whether it is using a toilet seat, when I suddenly stand up, or when I get up from the bed, I just lose, my head starts spinning, I start feeling dizzy, and then there's a blackout and a gray out. That is postural hypotension. For postural hypertension, we can do a TILT, tilt table test. But in India, we usually do not have the facility of a tilt table test. So all you will do is record the BP of the person in supine position, then ask him to stand. Do not record the BP immediately on standing. Give a lag period of at least 3 minutes to allow for the compensatory mechanisms to work. If you notice the fact that the systolic blood pressure of the person falls by more than 20 millimeter, that's again a MCQ statement, and diastolic blood pressure falls more than 10 millimeter of mercury after a lag period of 3 minutes, that implies the fact that person is having postural hypertension. Before I describe the next manifestation, can you tell me from your knowledge of pharmacology any drug which you can use to treat this postural hypertension? Very frequently prescribed in a diabetic outpatient department, especially if you are handling complications of diabetes in the long run. Drug of choice for postural hypertension will be an alpha agonist that will cause vasoconstriction. What is the drug of choice here? Your answer would be given as midodrine. So midodrine is a oral drug that helps you to mitigate the effect of postural hypertension and reduce the incidence of possible head injury in this person. Apart from this, as I've highlighted, diabetic persons can be having silent MI that will increase the chances of sudden death. So if he specially mentions regarding sudden death in a diabetic person, then two possibilities are to be considered: silent MI and hypoglycemic unawareness. You see, when we are hungry, we start feeling angry, we start having, I would say, mood swings. Then they might be sweating, there might be palpitations, we have this gnawing sensation in our stomach, we just need to eat something. So we will try to get up and go to a source of food. But in diabetic patients, they might be developing in the later part of the illness hypoglycemic unawareness. He's hypoglycemic, is not aware of it because the routine sympathoglycometric drive system is not working. So both of them can contribute to sudden death in a person, but the first best answer would be silent myocardial infarction. Apart from this, these patients can be having a disturbed sleep because of diarrhea episodes. They can be having constipation. So GI disturbances can definitely be anticipated due to autonomic involvement. In fact, here one more question can come up from pharmacology. What drug is used in diabetic diarrhea? Because we need to use a drug that has an anti-secretory action. Yes, guys. The drug that you will use in this case would be clonidine. So clonidine and midodrine, though you study about these drugs in pharmacology, I've just revised that pharma part for you. In diabetic diarrhea, we use clonidine. For management of patients of postural hypertension, we are using midodrine in the person. So it is rather diabetic neuropathy component has a lot of domains which can be asked in the exam. Another perspective that I can add to this discussion is that diabetic patients can be having a non-healing ulcer in the sole of the foot. In fact, in image-based questions, they can give you any ulcer. It could be arterial ulcer, venous ulcer, or let me say martoral ulcer. Martoral ulcer occurs in hypertensive patients with atherosclerosis. Non-healing ulcer definitely occurs in diabetic patients either on the sole, and especially on the sole, then it would occur mainly close to the heel, or it would occur on the metatarsal heads, because when you stand, the weight of your body will either fall on the heel or on the metatarsal heads, and these ulcers can definitely become nasty and can become infected, and in some cases they might even be maggots coming out of it. So in a non-healing ulcer on the sole of the foot of an individual, the contributing factors are neuropathy as well as angiopathy. Well, why does a diabetic person develop a non-healing ulcer? I can say I had told this diabetic person never walk with bare feet. Always, if you want to go out in the morning for a morning walk, never walk bare feet. Always, like, people in India, they have this habit of walking barefoot on the grass. They like these naturopaths and all these people, they say walking barefoot on the grass increases circulation in the body. It doesn't, obviously, you know that. Now this guy, he is having diabetic neuropathy. There's decreased sensation in the sole, and he overstepped maybe a small stone, or he overstepped a piece of nail, or there was some minor injury in the sole of the foot. He did not feel the pain at that particular point of time, or he did not feel the discomfort at that point of time. But then this injury that will occur, it's not gonna heal. Why it's not gonna heal is because in diabetes, in the long run, the blood vessels also become narrow. So there's an angiopathy component. Angiopathy would mean that there would be a delayed healing that will be occurring. And the consequence of this delayed healing will be a non-healing ulcer. The neuropathy component obviously contributes to the neglect, because you see, if you and me get injured in the sole of the foot, it's gonna hurt very bad. So we will avoid weight bearing on that foot. We will put up an antiseptic bandage. We'll keep that area clean. I want an injury in the sole of my foot to heal as early as possible so that I can ambulate and walk normally. But these people will definitely neglect this injury. Apart from this, increased amount of sugar in the local tissues will contribute to increased incidence of infection and bacterial growth, and therefore the combination of these factors will contribute to non-healing ulcer in a diabetic that would be in the sole of the foot. The term that we will use to describe this would be called as a neuropathic ulcer. In contrast, when it comes to arterial ulcer, the arterial ulcer will always be in the dorsum of the foot. That is where the dorsalis pedis artery is, and a venous ulcer would be on the medial malleolus of the person. Since I spoke about cranial nerve involvement in this case, I wanna reiterate the fact that in a multiple choice question, if they say patient is having third nerve palsy with pupillary sparing, then what are the differentials that you need to consider? One of the most important differential that you need to consider is obviously diabetic neuropathy, but after that would be barrierism. If it's a unruptured barrierism, if you listen to the discussion of subarachnoid hemorrhage, I have explained the fact that if a person is having an unruptured berry aneurysm, mainly located in the posterior communicating artery. You see, posterior communicating artery will run adjacent to the oculomotor nerve. So when this unruptured berry, when it will grow in size, it will press on this oculomotor nerve from outside. And as I explained, the fibers controlling the pupil are deeply situated. So when the pressure is from the outside, then LPS can be paralyzed, middle rectus can be paralyzed. So ptosis and squint will occur, but pupillary sparing might still occur. So diabetes mellitus, berry aneurysm, or arteriovenous malformations are reasons why a person would be having third nerve palsy with pupillary sparing. In contrast, if you go through the central nervous system, I have described certain stroke syndromes to you, especially brainstem strokes, where exclusive third nerve palsy with contralateral hemiplegia and other allied manifestations has been described. So from the neurology component, I want you to revise the literature of Weber syndrome, compare this with Claude syndrome, compare this with Benedict syndrome. I've done that in the stroke part, so you can go through that in case you're going through the endocrinology component initially. Then Weber, Claude, Benedict, and Miller-Fisher syndrome. Miller-Fisher syndrome is a variant of Guillain-Barré syndrome. In Guillain-Barré, there is ascending paralysis. Miller-Fisher is descending paralysis. So these are the times when I've described third nerve palsy. Let us also revise when do we read about sixth nerve palsy in an individual. Sixth nerve palsy is one standard feature of raised ICP because this nerve will travel through the subarachnoid space. You see, sixth nerve has one of the longest subarachnoid course. So when the pressure will rise, when intraocular pressure will rise, then the pressure subarachnoid space is rising. So it will stretch the sixth nerve and thereby sixth nerve palsy and diplopia looking laterally will develop in the person. Other important stroke syndromes which can contribute to sixth nerve palsy are Millard-Gubler and Fowell syndrome. And last but not the least, even Wernicke's encephalopathy, where we study about the mnemonic by the name of GOA, global confusion, ophthalmoplegia, ataxia. The ophthalmoplegia is the sixth nerve palsy component. So Wernicke's encephalopathy due to dry beriberi can also contribute to sixth nerve palsy in a patient. In fact, this slide, I have just highlighted some of the cranial nerve issues which have been discussed at various points of time, and you can just use this as a revision slide because these aspects have been discussed in neuro. Bilateral seventh nerve palsy is again a question that examiners love to ask because we encounter this in Guillain-Barré syndrome. Yes, in GBS we have ascending paralysis and then a facial diplegia and a bilateral seventh nerve paralysis will occur. And instead of writing GBS, he can write AIDP, that is acute inflammatory demyelinating polyneuropathy. Then could be sarcoidosis. Here you have non-caseating granulomas pressing on the seventh nerve contributing to this lower motor seventh nerve palsy bilaterally. Then could be Lyme's disease, which is secondary to a bite of a tick, and this person would be having bilateral seventh nerve palsy. The fourth and the last cause is Melkerson-Rosenthal syndrome. Now that's just a syndrome that name of which you need to remember, but I have highlighted these allied accessory points which you should also make an attempt to remember. These are all issues with respect to various cranial nerve involvements, but from diabetes perspective, if you get this diabetic neuropathy component right, the sensory, the motor and the autonomic, you are on right track for understanding this topic. Another complication that can be found in diabetic patients can be increased incidence of infections, and most of these will be very atypical ones. So let's discuss one of them in a case-based scenario. I'm today describing about this 60-year-old male. He's a known case of type 2 diabetes mellitus and is non-compliant in his medication. He has been brought to my clinic today by his son or daughter. Why? Because this person has had a tremendous personality change in previous few days. His son and daughter is saying that he's acting very aggressively. In fact, they're saying that he's urinating in his clothes. They have made him change his clothes. Again, he urinates in the pants and he does not feel any guilt about it. I mean, normally if a person urinates in clothes, it's obviously going to be bad smell produced. So the person will be getting embarrassed. Person will go to the washroom, change the clothes, wash himself. But this person is like sitting on a chair. He is urinated and he was okay the week before. And now he is having this antisocial behavior. He might be urinating and defecating in his pants. In fact, his son is also remarking that he is noticing his father having a black nasal discharge, and that is what sent the alarm bells ringing in my mind. There are two things that I have highlighted. One, a known case of diabetes mellitus who's non-compliant has been brought with change in personality, and second, there is a black nasal discharge present. So I requested his son to restrain his father so that I can put in a nasal speculum. And when I inserted a nasal speculum in the nostril of this person, I could see a dirty black fungal mass growing in bilateral nostrils of this person. I think by this point of time, you would have anyway come to the conclusion that what is the diagnosis in this case. But just to extend the question further, I decided to get a MRI head of this person. When the report of the MRI head came, it confirmed my worst fears coming true because the fungal mass had gone via the cribriform plate and was actually going and encroaching on the frontal lobe of the brain. In neurology, I have explained to you that a person with frontal lobe damage can be having marked personality changes. Person will have a total different personality from what he normally is. I mean, this guy, he was very social, he was very particular about hygiene. He used to always welcome everybody with folded hands. Now he's using abusive language to his own son and daughter, and he's urinating in his pants. When son is saying, why did you urinate in the pants, he's rather fighting with him or he's not giving an answer. He'll not even trying to get up and go to the bathroom and change his clothes. That kind of marked personality change is seen with respect to infiltration of the frontal lobe, and the infection that we're talking about in this diabetic is called as rhinocerebral mucormycosis. In fact, it can be a two-step question. He can also ask you what is the treatment for this guy, so you will be using amphotericin B. Yes, the same treatment that we discussed even in cryptococcal meningitis would be useful for management of rhinocerebral mucormycosis as well. And in this case, that beta-1,3-glucan test will not work. I've highlighted that in infections component that beta-1,3-glucan test is not useful for diagnosis of mucormycosis. So the infections in diabetes will be definitely more severe. The UTI component will be relatively more severe. Diabetic patients will also develop diabetic dermopathy. Now this is of particular interest to us because we have already discussed that most of these patients will be having delayed wound repair. The image that I'm showing you here is not a delayed wound repair. I just want to say that overall, the number one diabetic dermopathy that you will come across will be secondary to angiopathy component because the small blood vessels are narrow. Therefore, the repair process gets slowed and therefore the person would be having delayed wound repair. But over and above the delayed wound repair, they can be another manifestation of hyperpigmentation. This hyperpigmentation will be noticed even in patients of PCOD. The same hyperpigmentation is also noticed in type 2 diabetes mellitus. The hyperpigmentation will mainly be present in the back side of the neck. It can involve the flexural areas also, but mainly on the dorsum of the neck. That can involve the axilla also of the person. So acanthosis nigricans is a manifestation which can be seen not only with type 2 diabetes mellitus, not only with PCOD because it represents insulin resistance, but it can also be seen with pancreatic cancer and colon cancer. I've already explained to you the fact that Steve Jobs, the Apple founder, he had carcinoma pancreas. Well, how was it diagnosed? This white guy, I mean, he was an American, so he was a white guy. He started having this hyperpigmentation on the backside of his neck. When he went to his physician, the physician immediately on seeing that acanthosis nigricans manifestation ordered a CT abdomen that showed a pancreatic cancer that was in advanced stage and he died because of that. So acanthosis nigricans is not only a manifestation that is encountered in diabetic patients, but it is also a marker of internal malignancy, mainly GI malignancy like pancreatic and colon cancer and even stomach cancer. The image that I'm showing before you is exhibiting lot of erythema. This is the shin of a female patient of diabetes mellitus. She is having a lot of erythema, but along the central part there is some clearing present. You will notice that we study in dermatology regarding central clearing with respect to tinea infections, but here I'm not talking about any fungal infection. This is a very peculiar lesion where you can notice some definitive scaling present. You can notice erythema around the boundaries of the central clearing. The skin lesion that is found on the shin of diabetic patients would be called as necrobiosis, as the name suggests. The lesion would be referred to as necrobiosis lipidoica diabeticorum. In fact, if you compare necrobiosis lipidoica diabeticorum with pretibial myxedema, then pretibial myxedema will have a lesion which will be elevated over the skin. Here you can see it's contiguous with the skin. It's not a pretibial myxedema. Pretibial myxedema is an orange lesion on the shin that I've shown in the endocrinology part in Graves' disease, and it will also have an elevation above the level of the skin, whereas in this case there's no elevation. So the lesion shown here is necrobiosis lipidoica diabeticum. These are three skin manifestations, and if we just ask you to select one, the most common diabetic dermopathy is delayed wound repair. Over and above this, I also want you to remember that diabetic patients can be having acute complications. I have discussed the acute complications of diabetes mellitus separately, but here I'll just give you an insight into what to expect. The question will always begin by describing an unconscious, unresponsive diabetic patient. You very well know the fact that if a diabetic person is unconscious and unresponsive, then there can be two possibilities. Either he will be having metabolic problems that we will discuss, like diabetic ketoacidosis or non-ketotic hyperosmolar coma, or he's having stroke. So you need to keep both in your mind. On examination, the casualty, the heart rate of this person was 100 per minute. When I evaluated the blood pressure, it was 140 by 100. So as such, there is no need for any CPR in this guy. The neck veins were perfectly normal, so there was no features of heart failure in this person. I used a glucometer. I tested his capillary blood glucose. When I evaluated the capillary blood glucose, I found that the blood sugar was really very low. This could be a type 2 diabetes mellitus patient who took, let me say, glipizide, and then he forgot to have his lunch because he was maybe having hypoglycemic unawareness. So the capillary blood glucose has dipped to as little as 30 milligram %. All I need to do in this chap is get a IV line in place and then push 25 to 50% dextrose, and he will gradually start responding. If I don't have 25 to 50% at the moment, I can use 10% dextrose also, but then this person will definitely start responding. Now let me change the scenario for you. So in the MCQ, he has written that the glucometer had evaluated the capillary blood glucose of this person, and it is turning out to be 300. The blood sugar is not 30, it is 300 milligram %. Then it is obviously not hypoglycemia. So in these circumstances, I'll draw a blood sample of this guy, preferably a arterial sample. I will check for pH, I will check for PCO2 and bicarbonate values. And when I evaluated this, I came to know that the patient's pH was definitely lesser, bicarbonate was definitely compromised, so metabolic acidosis. So I decided to check for the urine ketones of this guy by dipstick, but urine ketones were negative. You see, if urine ketones are positive, it is definitely in favor of diabetic ketoacidosis, but I'm giving you a case where pH of the blood is 7.2. PCO2, let me say, is 40 millimeters of mercury. You can avoid writing PCO2, that will cause unnecessary confusion for you. But then yes, pH is less, bicarbonate is less, so it is metabolic acidosis. Normal pH is 7.35 to 45. Normal bicarbonate is 22 to 26. Here it's only 15. The ketones are absent. Random blood sugar I've checked again. I called up the lab. I said, I want a random blood sugar of this guy. That also came 300. So glucometer was giving me a right value, capillary blood glucose. This guy is not having diabetic ketoacidosis. Obviously, this particular person is having what you will answer as lactic acidosis. You see, there are no ketones, so it cannot be diabetic ketoacidosis. No? On contrast, if I give you a question in which PCO2 is optional for you if you want to note down, or even if you don't note down, it's okay. But I'm just creating a question where urine ketones of the person are positive and blood sugar random is 300 milligram %. In these circumstances, the diagnosis of this guy would be DKA, diabetic ketoacidosis. On the contrary, suppose the pH is normal, 7.38. Bicarbonate of the person and PCO2 of the patient is normal. Let me say bicarbonate is 24 milliequivalent. Normal is 22 to 26. So everything is normal. No. But in spite of that, the person is unconscious. So I'm wondering what's going on, man. What I'm finding in this guy is blood sugar is very grossly elevated to 600 milligram %. If the blood sugar increases to such dramatically high values, please remember, if the blood sugar of this person goes up to such dramatically high values of 600 milligram %, then when such large amount of sugar will go into the brain, well, sugar can cross the blood-brain barrier. So when such large amount of sugar will go in the brain, to balance the osmotic load, even water can go in. And if the water will go on, it will contribute to cerebral edema component, and this cerebral edema will explain why this patient is unconscious, unresponsive. The diagnosis in this case is non-ketotic hyperosmolar coma. So what I've tried to explain to you is that you should be able to evaluate why a diabetic person is unconscious, unresponsive. The first differential of yours would obviously be hypoglycemia. But if it is not hypoglycemia, you have to take into consideration lactic acidosis. The lactic acidosis that is present here, if it is without sepsis, then we will say it is type B lactic acidosis. If it is with sepsis, it is type A lactic. If stroke is there, no, then or let me say, if person goes into a septic shock, the underperfusional tissues, it is type A. If septic shock is not there, then it would be type B lactic acidosis. It could be induced by drugs, for example. And especially when it comes to the extreme right hand side, normal saline is the first line management for both diabetic ketoacidosis and hyperosmolar coma, and for both of them it would be regular insulin that would be used. The treatment of diabetic ketoacidosis and hyperosmolar coma is discussed separately, so go and check out that lecture. But I just want you to understand the fact that when it comes to unconscious diabetic, these are the differentials which are to be considered. And suppose, and listen to this word very carefully, if everything is normal in a sense that blood sugar is normal, there is no acidosis, even then the person is unconscious, then you definitely have to rule out the possibility of a cerebrovascular accident. Please appreciate metabolic causes are the first reason for unconsciousness, unresponsive state of a diabetic. Only if metabolic causes have been excluded, mark my words there, only when metabolic causes have been excluded that you need to take in consideration cerebrovascular accident, for which you will do a CT scan in the person. So whenever a question begins by saying unconscious unresponsive diabetic, what do you do first? Do you do a CT scan? Do you do a capillary blood glucose? You first do a capillary blood glucose. Rule out the metabolic causes first, then think in terms of cerebrovascular scenarios for this person. And well, normal saline has been discussed multiple times as fluid of choice. When do you give normal saline? You give it when a person's blood pressure is unrecordable. So if you read a question of a crashing patient, it is normal saline. In diabetic ketoacidosis, I've explained the reason. We don't give ringer lactate because ringer lactate is rich in potassium, and metabolic acidosis of DKA due to insulinopenia will also contribute to hyper K. So we will not like to worsen the hyperkalemia component by giving ringer lactate. We will give normal saline. Then hyperosmolar coma. The requirements of saline in hyperosmolar coma is higher, as much as up to 10 liters per day might be the requirement in the person. The normal saline can also be required in acute hypercalcemic crisis. I have tried to keep the discussion more for usage of normal saline from endocrinology perspective, because if calcium is very high, the high calcium component can contribute to systolic arrest of the heart. So even for hypercalcemic crisis, normal saline is used. Whereas ringer lactate is one which is recommended mainly for burns, it is for cholera, and it is also the fluid of choice for metabolic acidosis. Now listen to my words very carefully. Ringer lactate is the preferable fluid for metabolic acidosis because the lactate component will be metabolized by the liver to produce bicarbonate, and this bicarbonate will neutralize the protons. But diabetic ketoacidosis is the only acidosis where we don't use ringer lactate. Reason I've explained. In those circumstances, you will have to use normal saline. And if you're still not clear, I'll try to explain once again. You see, diabetic ketoacidosis is triggered by insulinopenia. You are aware insulin causes potassium to go inside the cells. Now, if there is a deficiency of insulin, then potassium will come out of the cells. If there is already a increased potassium in the body due to this insulinopenia component, if you will give ringer lactate which is having potassium, it can cause a diastolic arrest of the heart. Fluids are anyway important. You read about them in general surgery. I've tried to do it from the medical perspective, indications for normal saline, ringer lactate. And as far as the acute complications of diabetes mellitus are concerned, I've discussed them separately also. So please go through that lecture. And from the chronic complications component, I would especially like you to be very comfortable with aspects related to retinopathy, neuropathy. Diabetic nephropathy is one that I've not talked about here because that is discussed as a separate lecture in the kidney section. So these are the facts that I want you to keep on learning. Guys, I know this has been a long lecture. You are tired at the end of it, but I definitely want you to keep hammering because for you guys, one thing is there, knowledge is power. Whether it is Ayurveda people, whether it is Unani people, whatever the hell type of allopathy they want to mix with allopathy, the bottom line is we are superior as compared to these people. That will differentiate because as India is improving economically, people want to go to a better medical science, and better medical science is allopathy is what we are following. These guys, they are getting so many bias from the government of India, but you don't need to worry about it. What I want you to do is simply focus on your studies. Just make yourself solid. Just make yourself mentally so strong that nothing affects your career. And I'm very sure you guys will have very brilliant careers. All this nonsense is not going to affect you. Thank you so much for hearing me out.